Good afternoon, everybody. This will be a very short talk on how to ventilate ECMO patients. In fact, there has been recently quite a few differences in the way we have been ventilating ECMO patients in the past with some newer studies and newer thought processes. So I'm going to just share it with you. The principle of ventilation in an ECMO patient is to give lung rest and to decrease ventilator-induced lung injury to the maximum possible, because that is what improves the outcome of patients, and that is actually the principle of doing ECMO, because you want to give lung rest. Now, one of the measurable parameters which has been shown to directly affect mortality is the mechanical power of ventilator. The mechanical power of ventilator depends on certain things like the flow, tidal volume, PEEP set, and the driving pressure. And you also multiply this with the respiratory rate. So you can understand that there are certain things which we don't think are important in ventilation settings when we talk about lung injury, like the respiratory rate, like the flow, but all these play their role. And if you look at a patient whose mechanical power for ventilation is more than 17 joules, that is associated with death. The recent EOLIA trial on ECMO patients has also shown that if you can reduce the mechanical power of ventilation by 2/3, you can actually make a significant change in the mortality. But although the study was not powered or was not meant for this particular study. Now, what are the variables? The most commonly used mode of ventilation is controlled mode of ventilation. And although volume control was initially the method or mode of choice, but slowly people across the world are moving towards a pressure controlled mode of ventilation. There are certain things which should be taken care of and are important when we talk about lung rest and VILI. And these are the same as general principles of mechanical ventilation. Those things don't change whether the patient is just on a ventilator or is on ECMO. So the first is plateau pressure. We try to keep a plateau pressure of less than 30, less than 25 is better. We try to keep a tidal volume of 6 ml per kg. There is some studies which are coming up that probably less than 4 ml per kg may be even better. It's called the ultra protective tidal volume, but there is not enough evidence to suggest less than 4 ml per kg for all ECMO patients. Although most of the time, just after putting a patient on ECMO, the tidal volume that we can achieve is hardly 2 to 4 ml per kg, but that's a different issue altogether because of the lung stiffness. But in general, the tidal volume should be less than 6 ml per kg. Around 4 ml per kg is probably better. PEEP set should be a little high, not less than 10. Across the world, most of the people set a PEEP of around 12 to 15 for an adult patient with a reasonable weight. The reason is because the whole purpose is not only to give lung rest, but also to keep the lung recruited. And that prevents atellect trauma. Lastly, FiO2. When we start the patient on ECMO, the FiO2 that is set on ventilator is around 100%. But slowly we try to come down as low as possible. And the target is to keep it less than 40. If the patient's saturation is anything between 85 to 90. We don't need a target saturation more than that. 85 to 90 on ECMO is good enough. What are the other modes of ventilation besides control mode? Well, pressure support is the next most commonly used mode. Many centers are using pressure support mode from very early if there is not much of dyssynchrony, because that prevents the de-recruitment of the diaphragm, the diaphragmatic paralysis, etc. APRV, there are few studies, but not enough evidence that it is a very good